Welcome to the live lecture for week number 3. Dr. Campbell here with you again this evening. I have a couple of announcements. Number one, I will be out of town next weekend, and I will not have my DeVry computer with me. And so I will not be doing the lecture for week 4 on Sunday. It will be on Monday. I don't want to have to pack up my office and take it with me, so it'll be on Monday next week instead of Sunday. The other thing is I have, and of course it'll be recorded. I have uploaded some files to the files area. One of them are the PowerPoint slides for tonight. Another one is a document that I provided last week, but I think a lot of people didn't look at it last week, so I uploaded it again, which is the tips for inpatient coding tips for new coders. Then I uploaded a coding clinic article that we're going to discuss later. And then I also uploaded how you find coding clinic articles, because I think some people still don't know how to find coding clinic, and coding clinic is very important to our process when we're coding. All right, so let's talk about this week. For week number 3, you have a light week. This is kind of unusual for this course, because normally you got about 4 chapters a week, but this week you only have 2 chapters, which are chapters 8 and chapter 9. In your course syllabus, I hope that you guys have seen, and I don't know about you, but I will tell you about me as a college student. One of the things that I always did when I was taking a class was to print out the syllabus. And so when you look at the syllabus, it actually tells you that you're only reading certain portions of each chapter. And that is because, as you guys know, the textbook that we have includes ICD-9 and ICD-10. And the focus of this class is on ICD-10. So make sure that you pay close attention to the pages in the chapters that you are supposed to be reading. Also, don't forget, if there are guidelines related to the activities for the week, you want to ensure that you are reading those guidelines as well. And the reason that you need to do that, and I'm sure that you saw this for week number 2, your quiz or your homework for the week really focused on the readings and your guidelines. And you cannot do the homework multiple times. You only can do it one time. So you really want to make sure that you read the guidelines, that you understand them, so that when you go to launch your homework, you're not having to spend your entire time looking in the book for the answer, that you kind of have a general idea of what the answer is. And when you go to look in your book, you're merely going to confirm that your answer is correct. One of the things that I think is very challenging about the homework is that it's a true and false question. And true and false questions can be very tricky because, if part of the sentence is true and part of the sentence is false, you're thinking, oh, I don't know what to do. I'm going to make it true. I'm going to make it false. So here's the rule. It's either true or false. Okay, so if it's either all true or if it's half true and half false, it's false. Um, there are lots of resources out there on tackling true and false questions, if you have some time to take a look at them. But I will tell you, on the HEMA exam, your questions are going to be multiple choice, and there will only be 4 answers for you to look at. Next week, what I have added to our agenda is I'm going to do I'm going to have some national exam type questions that we're going to go through at the very beginning. Just so you guys can really, really, really appreciate why it's important for you to take advantage of your resources now, and really understand what you are going to be expected to know. So it's even if it's the CCA exam or the RHIT exam, that without a shadow of a doubt, what you expected to know. And I think it can really help change the way you think about how you are attacking your materials. Also, the quiz for this week, week number 3, will be just like this past week, where it was really questions that were similar to the questions at the end of the chapter. And you should have also noticed that each question required 1 answer. And let's see, I'm looking at the questions for week number 3, and it looks like, again, each question only has 1 code. Also, something that I should tell you, when you are posting your codes for your quiz, you do not need to provide any wording. So like, let's say it was diabetes mellitus. You don't need to provide the words diabetes mellitus and then the code. You just provide the actual code. Also, so that your instructors can read your answers, make sure that you insert the decimal point where it belongs, because I don't know about you, but I'm over that age where my eyesight likes to play tricks on me. So it is very difficult to grade a coding quiz when someone has done something like E11-9 or F10-20, because all the numbers start to run together. So for week 3 going forward, make sure that you insert the decimal point. Also, if you are utilizing the encoder for your quizzes, you need to be very careful. Use your book as a backup for 2 reasons. 1, the encoder does not give you, if you're using the code finder, it does not give you the decimal point. That's number 1. Number 2, you really want to know how to utilize your coding manuals, because if you are taking the coding exam, the only resource that you are going to be able to take into the room is your coding manual. You will not be able to launch an internet browser. So it is in your best interest to ensure that you know how to use your manuals through and through. Very, very, very important. Let's see what else. So the homework and the quiz for weeks 3 through 7 is going to follow the same format each and every week. One more announcement that I wanted to make. I am trying to work on having another ICD-10-CM codeathon. And I could not have one this weekend because I had to do an audit yesterday morning. So I couldn't do it. I could not do it yesterday morning. And then next weekend I'm going to be out of town, so I cannot fit it in during this week, so it'll probably be the following weekend. I'll do the Saturday morning codathon, and it'll be just like last time. And you will get the notification with the link and all of that from your instructors, because I send it to the dean, who in turn sends it to all of the instructors. Okay, so some of you are saying that you're having difficulty with the encoder. I'm going to post a link that I posted last week in the live lecture, where I provided an example of how you use the encoder to do your coding roundtable. So if you have not, if you didn't see that link last week, I just typed it in there again. All right, so enough with that preliminary stuff. We have so much to cover tonight, and I have to get back to my audit when this is over, because I can only audit on the weekends, because I'm doing my DeVry full-time job Monday through Friday and Saturday and Sunday. But Saturday is when if I'm doing audits, I'll normally do them on Saturdays, and if I don't finish on Saturday, I will finish them off on Sunday. So this week, the first chapter that we're going to look at is for mental, behavioral, and neurodevelopmental disorders. So I am turning over to my physical copy of the guidelines, and they are on page 33. And I will tell you, mental, behavioral, and the neurodevelopmental disorders is kind of an area that I have grown to love over the years. And primarily one of the reasons is because there's a group of psychiatrists that I work with, that I audit their work, and I provide them with education. And I've learned so much about mental disorders and the references that they use as clinicians. And one of the references that they use as clinicians, we as coders or HIM professionals can also use that same reference to look up diseases when we need additional clarification. So the one resource, which is the DSM, happens to be one of your discussion board questions for this week. And the most recent version of the DSM, what I like about it is not only does it tell me about a disease that I'm not familiar with, it also gives me some potential ICD-10 codes. And of course, I got to look them up in my coding manual, look at my documentation, and ensure that that's the code that I want to report. But it really helps me ensure that when I am auditing a provider's record, when I'm educating them, that I'm speaking the same language that they are. The beginning of the guidelines talks about the collaboration that we must have with our providers. That is so very, very, very important, because we want to be of value to our providers, and we want them to continue to provide their quality care. All right, so mental behaviors, neurodevelopmental disorders, the guidelines. So there are two major areas of the guidelines. The first is related to pain disorders related to psychological factors. And there is a note that says we are to assign code F45.41 for pain that was exclusively related to psychological disorders. Then it goes on to further say, as indicated by the excludes note under code G89, a code from category G89 should not be assigned with code F45.41. So one of the things that is very important, and this is why I highly recommend that you use your physical coding manual, is because you want to ensure that when you're in the tabular listing and you are verifying your codes, that you are reading those instructional notes. And we talked about the importance of the instructional notes previously, so I won't go into that again. But just know that it's so very, very important that you verify your code in the tabular list and that you are reading those instructional notes. For those of you who missed the Codathon Part 1, where we did some hands-on coding, here's actually a link to that recording. So that was one guideline. Then it states code F45.42, pain disorders with related psychological factors, should be used with a code from category G89. So you stop there and you're thinking like, okay, what's the difference? Okay, here's the difference. F45.41, pain that is exclusively related to psychological disorders, we cannot use code G89 with that code. However, for F4542, pain disorders with related psychological factors, it should be used with the code from G89. So when you hear me say it's important to know the guidelines, that's because knowing the guidelines really assist us with ensuring that we are assigning the correct code based on the documentation and the guidelines. Okay, let's see what else we got here. Mental and behavioral disorders due to psychoactive substance use. So there are three areas that the guidelines speak to. One is related to the term in remission. And something that is important here is that they are stating that it is the provider's clinical judgment related to if the patient is in remission. And in remission are assigned based on the provider's documentation. So one thing that you have to understand, there's us, HIM professionals, and then there are physicians. Physicians, nurse practitioners, physician assistants, they learn how to treat their patients. We, as health information management professionals, RHIAs, RHITs, coders, CCAs, we learn our coding rules and our guidelines, and we have to apply those guidelines to the physician's documentation. So here, the guidelines are telling us that it requires the provider's clinical judgment as it relates to whether or not the patient is in remission. All right, the next guideline, psychoactive substance abuse, use, abuse, and dependence. Now, what's really funny about this particular guideline, and I have to chuckle every time I see this, when I first saw it, I said, okay, I'm reading this and it doesn't make any sense. Let me read it again. Sometimes you got to read things more than once so that you can ensure that you understand it. And just know, guys, that it's normal in college to read things more than once in order for it to stick. So I read the guidelines and it states, when the providers, and for those of you who are wondering where I'm at, I'm looking at the actual guidelines. And I have a physical copy of the guidelines because my eyeballs require larger print. And on page 34, when the provider documentation refers to use, abuse, and dependence of the same substance, alcohol and drugs, only one code should be assigned to identify the pattern of use based on the following hierarchy. Now, this is where I personally got confused, and once I read it, I'm like, oh, easy peasy. Here's the bottom line. The patient is either going to be coded as abuse or dependent. So let me show you why. The first bulleted item says, if they use it and abuse it, it's abuse. If they abuse it and dependent on it, it's dependence. If they use it and abuse it and depend on it, it's dependence. If they use it and they are dependent on it, it's dependent. So they're either using it or they are dependent upon it. So, and then the next guideline, psychoactive substance use, they kind of reiterate that as with all other diagnoses, the codes for psychoactive substance use should only be assigned based on the provider's documentation and when they meet the definition of a reportable diagnosis, and they refer us to section 3 of the guidelines, which are reporting additional diagnoses. So let's just quickly go over to the guidelines that they're talking about, because I don't know if some of you haven't had a chance to look at it, but let's just look at this again just to make sure everybody got it. Just to make sure. So this is page 99 in the physical guidelines, and Tracy is going to be my code book page number person. She's going to tell you what page it's on in the physical in your coding manual, but in the big 100 and page 15 packet, it's on page 99. So when we were looking at the psychoactive substance use, it told us when they meet the definition of a reportable diagnosis. So on page 99, section 3, reporting additional diagnoses, there's a statement there that you have to commit to memory, which states, for reporting purposes, the definition for other diagnoses is interpreted as additional conditions that affect patient care in terms of requiring clinical evaluation, therapeutic treatment, diagnostic procedures, extended length of stay, or increased nursing care. Now, in the document that I gave you, which is called Inpatient Coding Tips for New Coders, one of the things that you will find in that document is that we have identified for you in really, I believe, good detail relative to some examples of those additional diagnoses. And in fact, we state that diagnoses that relate to an earlier episode, which have no bearing on the hospital stay, are to be excluded. That's probably the tricky part, is knowing when to exclude them. So don't get frustrated with yourself when in the coding roundtable, maybe you had extra codes and the answers come out and those codes weren't a part of the answers. Don't be frustrated, because new coders tend to overcode because you think it's listed, we should code it. And that's not always the case. So we're going to talk about this a little bit more shortly, but I wanted to point that out to you if you had not had a chance to read that, because it's some good stuff in the guidelines, but you got to know how to use them. All right, the next set of guidelines are for the nervous system. The nervous system has several guidelines, and we're not going to be able to go through each and every guideline. I just want to tell you that, because if I sat here and read each and every guideline to you, we would never get off of this. So let's look at a couple. Dominant and non-dominant side. So codes G81, G83.1, 2, and 3 identify whether the dominant or non-dominant side is affected. And the guidelines state, should the affected side be documented but not specified as dominant or non-dominant, and the classification system does not indicate a default, the code selection is as follows. And you can read what the selection is. But I just wanted to point that out, something very, very important. Okay, next category is category G89. We just saw that, right, in the previous guideline, because keep in mind, patients have multiple conditions. So you may, on one chart, have to look at guidelines for nervous system, guidelines for the heart, guidelines for the endocrine system, but that's the way the real world coding process works. And just so you guys know, it really takes about a year or two of day-to-day coding to really master the process. It's not something that you can learn in 8 weeks, or not learn, master in 8 weeks or 24 weeks. It's a process, okay? So codes in category G89, pain not elsewhere classified, may be used in conjunction with codes from other categories to provide more detail, and here's what's key, acute or chronic pain and neoplasm-related pain unless otherwise indicated below. And so they give you a few examples. If the pain is not specified as acute or chronic, or post-thoracotomy, or post-procedural, or neoplasm-related pain, you're not supposed to be using a code from category G89. So if they have pain and that's all they have, more than likely you won't be using this code. Okay, there's some other guidelines that you want to make sure that you read, but what's very important is where it says letter A, category G89 codes as principal or first listed diagnoses. And then it tells you when they are to be used as first listed. Then category or option B goes into use of G89 codes in conjunction with site-specific pains. And there are rules related to that. The rest of the guidelines are looking at post-op pain, chronic pain syndrome, neoplasm-related pain. Make sure that you read those guidelines. Again, I do not have time to go through all of them, but I encourage you to read them before you even read the chapter. All right, disorders of the eye and adnexa. ICD-10 is actually the first time that we have had guidelines on disorders of the eye at this level of detail. So disorders of the eye, disorders of the ear. One of the things that I want you to know up front is that in those two chapters of ICD-10, you're going to see lots of left and right codes. And you should remember from your first week reading, and if you did not get a chance to read the guidelines the first week, the very beginning of them, there is a rule related to laterality. And basically it says some does not mean all, some ICD-10 CM codes include laterality, specifying whether the condition is left, right, or bilateral. And this is where it gets very important. If no bilateral code is provided and the patient's condition is bilateral, we have to assign two codes, one for the left and one for the right. If the side is not identified, we don't know if it's left or right, then we would assign a code for the unspecified code. Now, you're probably wondering, why does she keep going back to these guidelines? The ultimate goal for all of you is to take your credentialing exams. If you are taking the CCA exam, you're going to take your coding manuals and you can take a dictionary in with you to the exam. If you are taking the RHIT exam, 20% of the RHIT exam, either 20 or 22%, let's just go with 20% for now. 20% of the exam is focused on coding. And you don't take a coding manual or any references with you to the exam. So it is very important that you learn the guidelines, so when they ask you a question, you'll be able to answer it off the top of your head because you won't have those resources in front of you. Okay, so let's see what we got for the eye. The eye is such a very powerful structure in our body. So first up, assigning glaucoma codes. Something important. Assign as many codes from category H40 that you need. Well, what do they mean by that? This is what they mean. Glaucoma has several types of glaucoma. We have, let's see, primary open angle glaucoma. They call that POAG. Okay, that's one type of glaucoma. We have EOG, another type of glaucoma. There are different types, and so if the patient has several types of glaucoma, we're going to have a code for each type. Also, the codes themselves identify the type of glaucoma, which eye, left or right or both, and what stage they're in. If you are not familiar with what is meant by glaucoma stages, I recommend that you do a little Google search. You probably can get a little picture that will identify what is meant by bilateral glaucoma. I'm sorry, what is meant by glaucoma stage. All right, then we have guidelines for bilateral glaucoma with the same type and the same stage. So if they have bilateral glaucoma and both eyes are documented as being the same type and the same stage, and there is a code for bilateral, you only need to report that one code with a 7th character for the stage. Something that just popped into my mind. The very first week, we talked about the 7th character. And I was looking at, I don't know if it was a discussion post or something, and there were a few people that were a little confused about the 7th character. So I just want to remind you that if a code has a 7th character and you do not have 6 characters that precede it, there is something that you need to use to fill in the empty spots. Does anybody remember what you have to use to fill in the empty spots? Yes, the placeholder of X. Very, very important. Okay. See, that could be a question on the exam that you would know, the placeholder X. All right. More guidelines related to bilateral glaucoma, but a situation where the patient has different types or different stages. So make sure you read that. Patient admitted with glaucoma and the stage progresses, according to the guidelines, you're going to assign the code for the highest stage that is documented. And then the last guideline related to indeterminate stage glaucoma has a seventh character assignment of 4 for indeterminate stage. And what's very important is that this character must be supported by documentation. So what I mean by that, the provider has to state that he doesn't know what stage the glaucoma is. Something I will tell you about providers. Providers, again, don't know coding. So you may, in fact, have to look at his documentation and see, oh, he documented that the patient was stage 2. He didn't use the word stage 2, but he used the definition of what stage 2 is. That's not a situation where you would query him, and I want to show you how this conversation would go. So he documents the definition of stage 2 glaucoma. And then you go and you query him and you say, Dr. Smith, you didn't tell us whether it was stage 2 or stage 3. And then Dr. Smith is like, what do you mean? It's documented right there. So when we query the provider, we need to ensure that it's not documented. Doctors don't like queries, I'm sad to say. Okay, for the disorders of the ear and mastoid, no guidelines. I will tell you, in your tabular listing, there are lots of instructional notes, so I just cannot emphasize enough the importance of using your manual, verifying your codes in the tabular listing, because that's going to be key. All right, next up on my agenda for today are POA indicators. So before you begin, let's get over to the POA indicators in the coding guidelines. So in the 115-page packet document of guidelines, the POA indicator guidelines are on page 105, and they go all the way over to page 115. And very shortly, Tracy, who is our code book expert, will tell you what page it's on in the physical code book, because I cannot have all those books and papers on my desk. I got enough sitting here right now. So the POA indicators really got its beginnings in 2008. And the president at the time, which was George Bush, signed into law the Deficit Reduction Act. And the Deficit Reduction Act was one of many initiatives where the government is trying to figure out how to not pay us for situations where we, and not we as the HIM professionals, but we as an organization, causes a patient to have a condition or an infection during the hospital stay. And from their perspective, hey, hospital, you caused the patient to have a stage 3 or stage 4 ulcer and it wasn't present on admission. You got to pay for that. Think about it. Patient comes to the hospital, is admitted, no ulcers whatsoever. The doctor writes an order to turn the patient every 2 hours because maybe the patient can't turn on their own. And those orders are not followed out. And the patient gets a stage 3 or 4 ulcer. The government, aka CMS, is like, hey, they got a stage 3 or 4 ulcer because you didn't turn them like you were supposed to. You pay for that care. Okay, so let's look at an example. It's always good to have examples. So 79-year-old female admitted with congestive heart failure and a decubitus ulcer on the left heel, DRG 291, has a weight of 1.2585. Remember, when the weight is over 1, it's a sicker patient and we get paid more money. But let's look at a 79-year-old female admitted with congestive heart failure and developed a decubitus ulcer on the left heel. From Medicare's perspective, that ulcer was not present on admission, and as a result, they ignore that diagnosis. They just completely ignore it like it's not even on the claim. And instead of us getting a DRG 291 with a weight of 12585, we get a DRG 93, which has a weight of 0.8765. Does everybody understand this concept here? What CMS realized they needed to do? Yeah, they're like, hey, you don't wash your hands and the patient gets a hospital acquired infection. Hey, hospital, we're not paying for that. Your patient is in your care and they fall out of the bed. Guess what? We're not going to pay for that. You know what I mean? So Medicare has gotten very, very, very smart. All right. So while we may code the conditions, we put a POA indicator of no, but we know that we're not going to get paid. So we still code it, but we're going to put that POA indicator onto the claim because it's a condition that the patient has. It just happens to be something that we, it wasn't present on admission. So in terms of the weight, the DRG, I saw someone say, well, how do you find the DRG? So I'm going to post, once again, the video that I did last week. If you were in my class, you got this video during week number 1 in the coding roundtable. If you are not in my class, I distributed it last week during the live lecture in the chat box. All right, so there are some hospitals that are exempt from the POA indicator and the concept of hospital-acquired conditions. So those hospitals are listed here on the screen. I won't read these for you because you have the slides for this session, so you can have them for future use. And Tracy, I will get the link to the dean, who will then have to get it to the instructors, because I do not know all of the instructors that teach coding, because there are a lot of them. I'm the only full-time instructor, so I will get the information to her and then she'll distribute it to everyone else. But there is the link right there in the chat box. It's about 19 minutes long, and it's just me really walking you through using the encoder with case number 11 from the roundtable number 2. Alrighty, so now it's time to have some fun. Because most people struggle with assigning the POA indicators, we're going to play a little game. And in this game, I'm going to give you a scenario, and you're going to identify if it is yes, no, unknown, so U, W, clinically undetermined, or E for exempt. And did you notice that I repeated? You are going to tell me whether it's Y, N, U, W, or E. So in the physical coding guidelines, something I will tell you, if you have not had a chance to review the POA guidelines, some of these are going to stump you because the objective of these questions are for you to apply the POA guidelines. So let's get started. The physician documents in the patient history that the patient is admitted for acute and chronic condition, chronic bronchitis. These conditions are coded to J20.9, J42. What are the POA indicators for acute and chronic bronchitis? Is it yes and yes, no and no? You know, what's your final answer? So the correct answer is actually yes and yes, because here's the deal. If you have a chronic condition, it's in your body. If you have an acute exacerbation, it's present on admission. So for example, I have asthma. I'm on medication for asthma. I'm not sick right now. So right now, I just got asthma, right? Well, what if I have an asthma attack after this meeting today? So I have chronic asthma, but now I'm having an acute exacerbation of my asthma. Are both of them present on admission? You bet, because it's in my body. I'm being treated for the asthma on a regular basis, but I'm not having the problem where it's keeping me up all night and I'm having to use my inhaler. But once I do transition over to that state, I'm now in an acute exacerbation. And so yes of them would both be present on admission. Okay, next. Following inpatient abdominal surgery, the patient develops nausea with vomiting, which is coded to R11.2. Supply the POA indicator for nausea with vomiting. Okay, so I think we need to review the guidelines for POA indicator. So where's Tracy or Marisol? I'm on page 105 in the physical, the big packet of guidelines. And I saw Marisol or Tracy post the page number. I think you said page number 30. But look at general reporting requirements. General reporting requirements. Second paragraph says, present on admission is defined as present at the time the order for inpatient admission occurs. Conditions that develop during an outpatient encounter, including emergency department, observation, or outpatient surgery, are considered present on admission. So let's look at some more. Let's look at some more. The key here is, was the condition present at the time of admission? Was the condition present at the time of admission? So, following inpatient abdominal surgery, the patient develops nausea with vomiting. Was it present on admission? And the answer is no. The reason that we're playing this game is because in your coding roundtables, you have to assign the POA indicators to different cases. And you got to know the rules in a smaller scenario in order to apply it to that medical record. Let's keep going. A patient is admitted for treatment of a lacerated spleen as a result of an automobile accident. Documentation also indicates the patient has sickle cell disease. 2 days following admission, a diagnosis of sickle cell crisis is made and the patient is treated. This is coded to condition D57.0. What is the POA indicator for sickle cell disease with crises? Because that's what D57.00 is. So, some of you are saying, yes, no, I'm not sure. So, let's look at a guideline. Let's look at a guideline. The guideline that I'm going to look at is on page 108 in the big packet. The title is combination code. So if you're looking in your physical coding manual, you'll want to find the guidelines for combination codes. And let's see what it says. Assign N if any part of a combination code was not present on admission. Assign no if any part of the combination code was not present on admission. So the patient has sickle cell, but at the time of admission, were they in crises? No. So the POA is no. Okay. You guys see why the guidelines are so important? So it's not about what you think it should be. It's about what the guidelines say we should do. And that's one of the challenging parts about coding, is that you're like, well, that just doesn't make sense. But those are the rules. You guys remember when you had ICD-10 PCS coding, and you learn the words excision versus resection, and you're like, whoa, whoa, whoa. When I learned medical terminology, excision and resection, that's the same thing. Not according to ICD-10 PCS. Excision is to take out part of a body part. Resection is to take out all of the body part. So what is key? What is key are those rules. They are so important. So I hate to say this, but if you guys did not read the POA guidelines, please put this on your list of things to do this week. Very, very important. All right. A patient is admitted with the diagnoses of cough and fever, with the subsequent diagnoses of aspiration pneumonia. The physician has documented in the patient history and the discharge summary that the patient has suffered a previous CVA with residual dysphagia. The dysphagia is reported with code I69.991. What is the code for the dysphagia? Okay, you guys ever remember what your mother told you and you didn't listen? So remember I said you got to read those guidelines? I know my class is the people who are in my two sections, they probably are like, does she ever go to bed? Because I'm always sending them some type of email or something. So you have to read the guidelines. So I am looking at the exempt list in the guidelines. I'm in my big packet with the big words, page 110. If you're in the physical coding manual, look for the categories and codes exempt from the diagnoses present on admission requirement. Page 31, Tracy says. So, looking at the exempt list, diagnoses present on admission for these code categories are exempt because they represent circumstances regarding the healthcare encounter or factors influencing health status that do not represent a current disease or injury or are always present on admission. If it's on this list here, it's exempt. So, what's your final answer regarding this case? So, the final answer. Do 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 do. Do 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 do. Well, the answer is exempt because I-69, the category of code I-69, is on the exempt list. So if you notice page 31 in your physical book, I'm on page 110 in the Big Fat Guidelines. I-69, sequela of a cerebrovascular disease, is on the exempt category. So all the codes that fall under the I-69 category, they are exempt. Now you see why you got to read these guidelines? Hint, hint, hint. And I know my class is like, she's making this harder than it is. No, there's a lot to it. And that's the reason why I love doing these lectures, because I want to give you some tools so that you can be successful. Very, very important. Next up, patient is admitted into the outpatient surgery center of the hospital for elective repair of an inguinal hernia. Following the procedure, the patient develops acute exacerbation of COPD, and the patient is subsequently converted to an inpatient status and admitted to the hospital. What is the code, or not what is the code? The code for the acute exacerbation of COPD is J44.1. So the question is, what is the POA indicator for the COPD? Ho, 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 ho. Well, I have selected questions that specifically are tied to a guideline. There is a guideline that states, condition develops during an outpatient encounter prior to inpatient admission, which says assign yes for any condition that develops during an outpatient encounter prior to a written order for inpatient admission. So once again, I hate to sound like a broken record, how important are these guidelines? Very, very, very important. So those of you who are either attending the live lectures or you are listening to the recordings, you are the advocates for your teammates, your roundtable teammates that are not listening to the recording. Because it's okay if you can't attend live, but you got to listen to the recording. So you guys are like the advocates for them to say, hey, your POA is wrong, and this is why. We played a game in the live lecture and you missed it. You need to go and listen to it. All right, let's keep going. An obstetric patient is admitted in labor. The patient requires a cesarean section for diagnosis of failed forceps delivery. The code reported for this is 066.5. What's the POA indicator? Evan says, you're not going to get me. Sharice and Tracy and Alicia and April and Marisol and Holly said the same thing. Oh, you must have saw that code on that list, huh? Darn it, can't get you guys twice. I tried, though. I tried. The last group I got twice. Okay. A patient is admitted with severe arm pain and heartburn. Has a past history of coronary artery disease, status post myocardial infarction 1 year ago. Admitting diagnoses was rule out myocardial infarction versus unstable angina. Final diagnosis is impending myocardial infarction. What should be the POA indicator for impending MI? Oh, well, there's a guideline. Conditions documented as impending or threatened at the time of discharge. If the final diagnosis contains an impending or threatened diagnosis, and this diagnosis is based on symptoms or clinical findings that were present on admission, we assign yes. If the final diagnosis contains an impending or threatened diagnosis, and this diagnosis is based on symptoms or clinical findings that were not present on admission, assign no. So what's the answer for this one? Is it no or yes? Read that guideline to yourself real quick, because some of you are saying no. And then Sharon, Jennifer, and Cerise are saying yes. And Dana is saying yes. Look at those guidelines again. What are the signs and symptoms of a myocardial infarction? So you guys know that disease process class that you have to take? This is one of the reasons why you have to take it. So this answer is yes. Yes, yes, yes. A patient is admitted to the hospital ICU for severe chest pain with a previous history of myocardial infarction, coronary artery disease, and hypertension. Previously treated with a PTCA. The admit diagnosis was acute non-Q MI. 3 days following admission, nosocomial pneumonia is diagnosed and the patient is treated. What is the POA for the pneumonia? So the answer is no. The answer is no. You guys are correct. Okay, we're almost done with these. We got to move on. A patient is admitted with a diagnosis of severe anemia, 1 week history of black and tarry stool, with subsequent diagnoses of a duodenal ulcer with hemorrhage. The patient has been treated with 3 units of packed red blood cells and an esophageal duodenoscopy with cauterization of ulcer. What is the POA indicator for the duodenal ulcer with hemorrhage? Okay, you guys are correct. It is yes. Patient is admitted to the hospital, status post-fall, complaining of pain, and is diagnosed with a right enterotrochanteric fracture of the femur. An immediate open reduction internal fixation is performed. 3 days following the procedure, the patient develops fever, redness, pain at the surgical site, diagnosed with the post-op infection, cellulitis of the hip, status post. What is the POA indicator for the post-op infection? And you guys are correct again. It is no. Patient is admitted to the hospital for severe abdominal pain, found to be secondary to appendicitis. Patient had a laparoscopic appendectomy. 3 days after surgery, patient develops tachycardia, fever, leukocytosis, and hypotension, and they now have sepsis. POA for sepsis is no. You are correct. You are correct. You guys are on a roll here. Okay, let's see if I can get you with this one. All right. A patient with severe cough and difficulty breathing is admitted from a private physician's office. Following hospital workup, a malignant neoplasm of the patient's lung is diagnosed. What is the POA indicator for the malignant neoplasm of the lung? Darn it, I couldn't get you guys. You are correct. There is actually a guideline that states assign yes for conditions diagnosed during the admission that were clearly present but not diagnosed until after the admission. The neoplasm didn't just show up while she was in the hospital. The cough and the difficulty breathing was because she had it. Yes. Okay, next up. Patient with diabetes mellitus is admitted through the emergency department on day 4. The physician documents uncontrolled diabetes. What's the POA indicator for uncontrolled diabetes? So, was the diabetes uncontrolled when she was admitted? He, she were admitted? Where does it say that? So she got diabetes, so you can't assume they were admitted with diabetes, but it didn't say that it was uncontrolled. On day 4, the physician documents uncontrolled, so it would be no. So let me explain to you why this could be the case. The patient can have diabetes, be admitted to the hospital for something else, and then while in the hospital, their diabetes is now uncontrolled. That doesn't mean it was uncontrolled at the time of admission. If it was uncontrolled at the time of the admission, the doctor would have said it. All right, next up. Patient is admitted with gastroenteritis with a history of AFib that is maintained on medication. No AFib is noted during the hospitalization. What is the POA for the AFib? Now, unfortunately, When you are reading your records, nobody's going to be making some of the words sound louder. So that's where hopefully you will remember this lecture and say, well, wait a minute. They're taking medications for it. You don't take medications just because, right? It just happens to be the medication is controlling the problem, but it's still present on admission. Okay. Patient is admitted with a hemoglobin of 9.6, which is low. Anemia is not documented until 2 days after admission. What is the POA indicator for anemia? So here is the last scenario for POA, and I'll just read something to you from the guidelines. If at the time of code assignment, the documentation is unclear as to whether or not a condition was present on admission or not, it is appropriate to query the provider for clarification. We as coders cannot code based on a test result. Yes, you learn the different clinical indicators, but we can't code based on an abnormal finding. We got to query. So that one we have to query. All right, so that was lots of fun, and now we must get to something that is not as much fun, or maybe not as much fun last week, which was inpatient coding. So this is the last part of our live lecture for today. So inpatient coding, where you have to read through medical records, sometimes typed, sometimes not typed. It's a very challenging process that really takes time to master. Inpatient coders on a day-to-day basis, 8 hours, are coding somewhere between 2 and 4 records per hour. Let me say that again. Inpatient coders are typically coding 2 to 4 records per hour. You are coding 2 per week. With coding 2 per week, something that I want you to know, because some of you are so hard on yourselves, what I want you to know, with coding 2 per week, you are not going to master the process. You're going to learn the process, but you won't master it until you're actually doing it every day, 8 hours a day. And typically, if you get a position as a brand new inpatient coder, you're going to have someone that is monitoring 100% of your coding, and they're giving you feedback on your coding and how you can improve. So don't beat yourself up if you're like, oh, I missed that one code, I didn't see it. It's okay, because you're given credit for your participation in the roundtable. Get that first post in by Wednesday with your answers to both cases. That's your 10 points. Then do your 2 follow-up posts to your classmates based on the instructions under assignments. The goal is for you to learn the process. So there are a few things that I noticed last week that some people struggled with that I want to talk about now. First is the definition of principal diagnoses. The condition that's established after study. Now, during week 1, you were reading or were to read chapter 3 in your textbook. And chapter 3 in your textbook spoke a lot about the UHDDS, Uniform Hospital Discharge Dataset. The UHDDS is where we get our definition for the principal diagnoses. I want you to keep in mind that there are some rules related to which of the conditions that the patient has can be principal. If you have not read section 2 of the guidelines, in the physical copy, the big not 115 pages, section 2 is on page 96, 97, and 98. Very, very important. In the physical book, it's somewhere in the pages that Tracy, Marisol, or Sharon or somebody's gonna say in a few minutes. Okay, page 27. If you did not have the opportunity to read chapter 3 during week 1, please do yourself a favor and read the guidelines. So why do you need to read them? Because your MSDRG determines the reimbursement. So our role as the coder is to review the documentation and select the correct principal diagnoses. Sometimes it's not easily identifiable. That is true. But this is what you want to think about. Which conditions required more resources during the stay? Which required more workup during the stay? That could be one reason that it can be principal. Other reasons, those guidelines on page 96, 97, 98, and then in the physical code book, page 27. So let's look at an example. Now, I don't know if it was week 1 or week 2. We talked about the fact that MSDRGs has a 3-tier structure. Does everybody remember that? MSDRGs has a 3-tier structure. And if you do not remember that, in the doc sharing area of the course, there is a document, and let me find mine because I have my binder that I recommended that you all have. But there was a document in doc sharing called the Acute Care, what was the name? Acute Care Fact Sheet, something like that. Acute Care Fact Sheet. And in that document, one of the things that they talk about is the fact that there are 3 levels of severity in the MSDRG system. And the 3 levels, I'm going to type them here. Tier 1 has an MCC, Tier 2 has a CC, and Tier 3 has no MCC or CC. Well, what does that all mean? This is what it means. Your MSDRG is driven by your principal diagnoses, but your secondary diagnoses can represent a CC or an MCC. And if they represent a CC or an MCC, it takes you from a tier 3 MSDRG to a higher tier of a 2 or a 1. Now, if you're like me, you're a visual learner, so let's see a picture. A picture is worth 1,000 words. Here are 3 patients with COPD. One is a tier 1, one is a tier 2, and one is a tier 3. Now let's let that picture marinate for a second and tell me what you notice. Tier 1 pays the most. But let's see if there's something else that you notice. You as the coder, if you don't pick up the secondary diagnoses, what can happen with the reimbursement? The hospital can lose money. So here's the cool thing. This is the coolest thing that they ever could have invented. You guys know that 3M encoder? Remember the 3M encoder? The 3M encoder does the work for you. What do you got to do? All you got to do is code the record, get your diagnoses, you plug your diagnoses into the encoder, and the encoder gives you the DRG, and it gives you the weight. And the encoder knows if the secondary diagnosis is a CC or an MCC. Does that make sense to you guys? That the encoder knows. We don't got to memorize. Now, you know, for those of you overachievers, if you want a list of which codes are CCs and MCCs, I can send one to you. You can send me an email. I'm going to put my email address in the chat box. You can send me an email, and I'll send you the list, but I will tell you, it's a lot of more paper, and I personally don't have the list printed out, okay? So look at the pages before you print it out. I don't have mine printed out because the encoder tells me, so I don't put it out. All right, so you guys see now why it's important to select that principal diagnosis, why it's important to follow those guidelines. All right. So if you did not listen to the week 1 and week 2 live lectures, you really do, because what we're talking about from week to week, we continue to expand on what was covered, and you can see how we're just building and building and building. All right, let's talk about secondary diagnoses. But before we do that, I want to mention that in ICD-10 PCS, you had guidelines. They were about 15 pages long, and in the back of those guidelines, there was a definition of principal procedure. Principal procedure is one that is done for definitive treatment rather than diagnostic or exploratory purposes. One that is necessary to take care of a complication. So, in the coding roundtable, you may notice we're not going to code chest x-rays. We don't need to pay an inpatient coder $25, $30 an hour to code 500 chest x-rays that we're going to get paid $23 a piece for. So, as the inpatient coder, we are only coding those definitive procedures, the ones that are treating a problem as opposed to diagnosing a problem, or a procedure that's taking care of a complication. All right, now, secondary diagnosis. Oh, wait, before I go there. The procedures that we do not code, the hospital still codes them, but can anyone tell me how we get the codes for those chest x-rays and Foley catheters and IV insertions? Yes, the charge master. Yes, the charge master. Okay. Other diagnoses. I got to speed up. Other diagnoses. One of the challenging things is to determine which secondary diagnoses we need to report. So we saw earlier section 3 of the guidelines where it talked about other diagnoses. And other diagnoses really have certain criteria that have to be met. It has to be significant to the hospital encounter. So conditions that coexist at the time of admission, that develop subsequently, that affect the treatment, that affect the length of stay, we can code those. Conditions that relate to an earlier episode that have no bearing on the hospital stay, we don't code those. This is important to know because of that MSDRG system and those 3 tiers, because the secondary diagnoses, if it's treated and if it's a CC or an MCC, we can get a higher reimbursement. And we want the hospital to get paid for the services that it has provided. So we saw earlier that other diagnoses that require clinical evaluation should be treated. Well, what do we mean by clinical evaluation? There was some testing for it. There was a consultation. There was an observation status for that condition. That is something that requires clinical evaluation. What's meant by therapeutic treatment? Something to treat the problem. So if it's a diagnosis that requires us to give the patient a medication. So a patient has diabetes and we got to give them insulin. Patient has asthma and we're giving them their asthma medications. Patient has hypertension and we're going to give them their hypertension medicine during the hospital stay. Patient has hyperlipidemia and we're going to give them that medication during the hospital stay. If we have to care for that condition during the hospital stay, that's a secondary diagnosis that we can actually capture because we are doing the work. It affects the patient care. Other diagnoses, diagnostic procedures. If there is a diagnostic procedure done to determine the underlying cause, we can capture that as a secondary procedure. So let's think about it. What are some diagnostic procedures? EKG, EEG, EGD, MRI, all those diagnostic tests that can be used to determine the underlying cause. Okay? Conditions that extend the length of stay. Conditions that require monitoring. Conditions that require further investigation, or we have to watch them, or it requires an additional hospital stay. It is a secondary diagnosis that can be reported. Increased nursing care. What do we mean by that? Well, more medications. Additional nursing care that is required during the hospital stay. Okay, let's see. Previous conditions. Sometimes the previous conditions are on the discharge summary. Other times the previous condition is on the H&P. Other times the previous condition is on a progress note. But what you have to remember is it a condition that falls into one of those other categories? Now, previous conditions may not be applicable to the hospital stay. If they are not applicable to the hospital stay, they are not coded unless the doctor, I'm not the doctor, the hospital policy says that we need to code them. So in some instances, previous conditions may have a Z code. For example, a patient has patient has an allergy to a medication. That's a Z code. Patient is an alcoholic and we do education, April. That's a Z code. So in some instances, previous conditions can be coded, but let me just explain something. Coding is not a black and white process. There is lots of gray. Okay, let's look at some more examples. Chronic conditions. I mentioned earlier that patients come to the hospital with all sorts of problems, but the question that we have to ask ourselves is, are we treating those problems? And are we treating them? Look for medication. I already gave you some examples of the hypertensions and the asthma and the diabetes, but think about other things. Congestive heart failure, emphysema, Parkinson's disease, COPD. The patients are on medications for this, okay? So if it's being evaluated or monitored, it can impact the stay. On the inpatient coding tips for new coders, I have actually provided you guys with a pretty extensive list of kind of the do's and don'ts of secondary diagnoses, and if you report the history of smoking, the current drinker, all of that. Some of those things are things that the hospital may tell you to pick up. Some of the things that the hospital may tell you not to pick up because it's not going to impact the reimbursement. Also, in terms of what order you put them in, it is the principle that drives the reimbursement. The rest of them can be in any order you want them to be in. But the principle has to be in that encoder in the principal position because that's what's going to drive your MSDRG. When the encoder sees your secondary diagnoses, then the encoder knows if it's a CC or if it's a MCC. Other things that you could see, patient is on medications for a long period of time. That's another example of something that you can capture as a secondary diagnosis. Long-term use of insulin, long-term use of aspirin, long-term use of blood thinners. Now, those codes like that, those generally will not change the MSDRG payment. But some hospitals will tell you to pick up all of that, and some hospitals will say, if it don't make us any money, code what makes us the money, and all that historical stuff, don't pick it up. Okay, intraco versus non-intraco conditions. This is something that's often very, very tricky. You guys had that class called, I don't know the number, but it's like Bio 260, Bio 275, one of those classes. Anyway, conditions that are integral to the disease process are not assigned a code. So, is the condition a sign or symptom? Is the first question that you have to ask yourself. Patient has chest pain and they have a heart attack. Chest pain is a sign or symptom of a heart attack, so we don't code it. If the sign or symptom is not associated with the disease process, then we don't code it. So, person has asthma and they have a rash. Guess what? The rash has nothing to do with the asthma. The patient has COPD and their toe hurts. The toe hurting has nothing to do with the COPD. The patient has nausea, vomiting, diarrhea, and they have gastroenteritis. Yes, those are signs and symptoms, so no, we wouldn't code it. So what you guys want to make sure you do, if you have not done so, is take out that book from your disease class and relearn the signs and symptoms for the different diseases. Okay, abnormal findings. We do not code them unless they are clinically significant. Here is what's key. The doctor has to state that they are clinically significant. You can't look at a lab result and say, oh, they got staphylococcus, so I'm going to assign a code for the staphylococcus. For example, the doctor can write down pneumonia, and that's it. And then you look at the lab report and you're like, wait a minute, they have staphylococcus. In this case, you gotta query the provider, especially if you see a situation when the provider has given the patient antibiotics. So if they have pneumonia, the lab report says staphylococcal, and they're giving them antibiotics, more than likely it's staphylococcal pneumonia, right? But we as the coder, we cannot just diagnose the patient. We have to query the provider and let him tell us what he wants us to do. So in terms of abnormal findings, you want to look for additional documentation so that when you are ready to query him, you can give him his own clinical documentation and say, hey, Dr. Smith, the patient that you diagnosed with pneumonia was given IV antibiotics, and the laboratory report says staphylococcal infection. Can you please further specify the patient's pneumonia? Not say, hey, Dr. Smith, does this patient have staphylococcal pneumonia? You have to give them their own clinical information and ask them how they want you to proceed. All right, so radiology or pathology reports. What to code and what not to code. This is a very tricky situation, okay? So what to code and what not to code. The coder cannot take information from these reports without attending physician confirmation. However, if the report provides additional detail, such as the area of a fracture, the location of the mass, and the doctor has already confirmed the condition, then we can code it. So let's look at an example. Let's say that the physician has already documented that the patient has a femur fracture. And when you're looking at the radiology report, they give you specific details about the femur fracture. We can code it. However, if the physician hasn't even documented the femur fracture, we cannot code it. All right, so let's talk about queries. The goal of queries is not to make more money. That is very, very, very important. It is not to make more money. The goal of a query is to improve physicians' documentation. During week number 1, you are provided with 2 articles related to the query process. Make sure that you read them. Those documents are the gospel as it relates to queries. That is what we follow in terms of when we query, how we query, why we query. It gives you examples because a HEMA suggests that the query has to be clearly and concisely written, number one. It has to contain precise language, have to be precise. And you have to present the facts from the medical record and identify why clarification is needed. So typically, we will present the scenario, we'll state a question that really is designed to ask the physician to make a clinical interpretation of a diagnosis. So he's given us the information, but we notice, hey, you didn't say it was staphylococcal pneumonia. We are querying them to get more information so that we can assign the code for staphylococcal pneumonia versus just pneumonia. Okay, so here are the reasons for when a query is needed. You guys read that in your AHEMA article, so I won't go over this again. I put these 6 areas on here because you're likely to see them on the final exam. Alrighty, when not to query. Do not query to question a provider's clinical judgment, okay? When you are querying, you have to query because there are clinical indicators that are leading to a disease, okay? For example, in one of the POA scenarios, we saw a situation where the patient had sepsis and the patient has fever, tachycardia, leukocytosis, hypotension. Those are all clinical indicators that indicate sepsis. So if you saw those clinical indicators in a medical record, you could query the provider to determine if the patient has something that stems from those symptoms that are listed. You can't just say, hey, doctor, does the patient have sepsis? You just got to tell them. They got the tachycardia, they got the hypotension. You have to state that information back to them. You don't query on each and everything. You query because you need greater specificity for a diagnosis. You don't query because you see an abnormal lab test. That abnormal lab test has to have some documentation in the record that's pointing to a specific condition. That's the only time we query. Not because you know all the different laboratory values for all the different tests, and you're like, oh, the computer generated laboratory report says that laboratory finding is high. That laboratory finding is high. What you have to understand is that laboratory tests are generally run by a machine. And the machine uses some criteria to determine if something is high or low. It is up to the doctor to determine if that finding is clinically significant. So what you have to do is look at the disease process. So if a patient's hemoglobin, hematocrit are low, the patient was transfused with some red blood cells, and you don't see any diagnoses for that treatment, that's an example of when you can query. And you can say, Dr. Smith, patient's hemoglobin was this, patient's hematocrit was that. The patient was transfused with 2 units of packed red blood cells. Is there a reason for this treatment? And then the doctor will say, oh yeah, the patient has blah, 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 blah. All right. At the very end, coding roundtable. So this week, once again, you have 2 cases that you are going to be doing. Case number 5. This is an easy one because you only have a principal diagnosis, 2 secondary diagnoses, no procedures. Now, let me just explain to you guys something that's very, very important. you are going to be looking through the medical record and you are going to be pulling out all of these different diagnoses. And you're going to be thinking, when the answers come out, well, why didn't we code this and why didn't we code that? Here is what I want you to understand. For the coding roundtable, we are coding the floor of what can be coded, not the ceiling. We are making the assumption that we work at a hospital that is very concerned about productivity, 2 to 4 records per hour. And at our hospital, they say you pick up your principal diagnoses, you pick up your significant secondary diagnoses, and you keep it moving. We don't want you to have a Z code for absence of a leg, absence of the appendix, absence, tubal ligation status, unless those conditions are pertinent to the hospital stay. For example, if I was admitted to the hospital today for asthma, and that's the only reason I'm there, who cares that I have a tubal ligation? Who cares that I previously had knee surgery? Those diagnoses are not affecting my asthma care. Now, if I have asthma and I also have hyperlipidemia and they're going to give me a pill for hyperlipidemia, then yes, I would code it. So keep in mind, we're coding the floor and not the ceiling of what can be coded. So case number 5, patient has a principal diagnosis of acute and chronic alcoholism. The patient has 2 secondary diagnoses, one of them being a risk fracture. The second happens to be a Z code for counseling for an alcoholic. Now, as it relates to the risk fracture, I have uploaded for you a document called Coding Clinic for 7th Character. And the coding clinic for the 7th character is very important for this case to ensure that your 7th character is appropriate for this patient's case. So for case number 5, that's all you need to code. The alcoholism, the wrist fracture, and then there's a Z code for the counseling for someone who is an alcoholic. That was the easy one. Okay, case 13. Here we got some procedures finally. Yay, you get to use your PCS coding skills. Okay, so this person, was this a lady or a man? I can't remember. This is the chart that's got all that handwritten documentation. And, well, no, not all of it's handwritten. Some of it's typed. But, all right. So, case number 13. Now, you'll notice, as I mentioned last week, these records are kind of old. They're from, 1983. So, again, because of HIPAA, we could not get access to current records, so we got to have these old records. This patient in case number 13, they were born in 1921, which would make them 95, which they could still be alive today because my grandparents are 95 and they're still alive today. But anyway, this patient here has a principal diagnosis of a cataract. Okay, that's the reason that they were admitted today. And this patient also has a relaxed corneal wound. A relaxed corneal wound. And this patient also has an astigmatism. And I'm just looking at the post-hospital instruction sheet, and I see all that right there. So, a relaxed corneal wound, an astigmatism, and further in the record, on the short stay record, the patient has an allergy to sulfa. So those are your four codes. The cataract is principal. The relaxed corneal wound is a secondary. The astigmatism is a secondary. And the allergy to sulfa is a secondary. And I'm sure you guys know the allergy to sulfa is a Z code. And I want to mention something that I stated last week, and somebody in my class asked me about it. I made a statement that Z codes, we don't get paid for them. And let me kind of correct that statement. Certain Z codes we do not get paid for. So allergy to sulfa, we don't get any extra reimbursement for that. But if you have a patient that's coming in today specifically for chemotherapy, radiotherapy, immunotherapy, which is a Z code, we would get paid for that. So when I said we don't get paid for Z codes, it was in the context of the allergy to sulfa, a history of breast cancer. We don't get paid extra money for those. Those are for informational purposes only. But there are some Z codes that are listed in the principal position that we will get paid for. I just wanted to mention that. Okay, procedures. 2 procedures. 1, the patient has cataracts, and during this hospital stay, they do a ECC with PI and IOLOS. Now, Google everything that you don't know. The I abbreviations, OD, OS, and OU, right eye, left eye, and both eyes. So ECCE, extracapsular cataract extraction, with PI is probably phacoemulsification. IOL is intraocular lens. So the first procedure, they took out the patient's cataract and they put in a lens. Your lens that you're born with, and they put in a new one. So that sounds like a root operation of replacement. Then the patient had this corneal wound, and what I want to point out, that you want to review the documentation to see why this patient had the corneal wound. It wasn't that it was an acute corneal wound. In the admission progress note, they mentioned that it's a post-op corneal wound. So what I want you to know is at the end of every chapter in your coding manual, there are codes that are specifically for intraoperative and post-procedural complications. That corneal wound code that you're going to pick up, make sure that it falls under the post-procedural complications area. H59, hint, 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 hint. All right, the second procedure is done to repair that corneal wound. So of course, sounds like a root operation to me of like a repair. All right, I'm gonna need to get a hit of my inhaler because that was a lot of information in 2 hours. Okay, guys, we made it to the end. I thank you guys so much for hanging in there. I am so sorry that these are so long, but I have so much information to cover that they have to be this long. And one of the things that you guys have to make sure that you do is ask your instructors questions during the week. I hear from instructors that they never hear from students, and that's not something good, guys. If you have questions during the week, you should be asking your instructors. You should not just be sitting there suffering in silence. You pay too much money to do that. Okay, so if you have questions during the week, it is critical that you contact your instructors. Okay, Holly, what is your question? I uploaded that again in the files area tonight, so you can grab that from the files area, which on my screen is directly above the chat box. I don't know what you guys' screen looks like, but mine is directly above the chat box. And there are probably about 5 files there. I lost track of how many they are, but they're about 5. Yeah, I guess the system has a limit to how many files you can upload. So I uploaded it, but I guess it didn't stay in there. Katrina, I gotta look at the schedule. If you click on iConnect in your classroom, it should tell you the time. I can't remember what time I scheduled it for. It has to be early because, and it's probably not gonna be at 5. I have 2 chats on Monday nights, one at 6 and one at 8. So if it was in there for 5, I probably have to go and change it until 4 o'clock because I have 2 other live lectures that I do on Monday night. So yeah, it's probably at 4 o'clock because I'm going to have one at 4, one at 6, and one at 8. Alicia, unfortunately, DeVry does not allow for extra credit. That is a university policy. So what I recommend that you do is see why you're getting things wrong. Was it a guideline? Was it that you didn't look it up properly in your coding manual? There has to be a root cause for why you got something wrong, and I would start there. But unfortunately, the university policy is no extra credit. In fact, there isn't even any room in the grade book to even type in extra credit. So, and I've been with DeVry for 8 years and no extra credit. Sorry. Okay, guys. Well, thank you so much for joining. I need to get to work so I can go to bed at a decent hour because I got to be up because Mondays are all about grading for me. It's the beginning of the week for you guys, but Mondays I grade all day long. So, alrighty, guys. Thank you so much. And make sure